Let's go through subarachnoid hemorrhage, a classic FRCR2B topic that's all about recognizing patterns and thinking about the underlying cause. When you see blood in the subarachnoid space, your first question should always be, is this traumatic or spontaneous? If there's no clear trauma history, angiography is usually needed to find the cause. A quick but important tip: if the blood is centered on the posterior fossa or around the foramen magnum, think about a posterior inferior cerebellar artery aneurysm or even a spinal AVM, and that means you might need to image the spine too. Now, there are also some mimics of subarachnoid hemorrhage to watch out for. In hypoxic brain injury, the brain can look diffusely hyperdense. This is the pseudo-subarachnoid sign. The giveaway is loss of gray-white differentiation rather than true sulcal blood. Polycythemia can also cause hyperdense blood, so the density alone isn't enough. Always interpret it in the right clinical context. Let's now break down the main causes. First, trauma. This usually gives superficial subarachnoid blood, localized to Ku or contracoup sites. It's not diffuse, and the pattern often matches the injury mechanism. Second, intracranial aneurysm, the most common non-traumatic cause. Here, the bleed is typically centered on the aneurysm site. So, blood in the sylvian fissure, think middle cerebral artery aneurysm. Blood in the interhemispheric fissure, think anterior communicating artery aneurysm. Aneurysmal bleeds usually fill the basal cisterns, whereas non-aneurysmal causes tend to be more sulcal. Sometimes you can even see the aneurysm itself as a small filling defect within the acute blood. Third, arteriovenous shunts. These can be AVMs or AVFs. An AVM is a tangle of abnormal vessels, a nidus, with both feeding arteries and draining veins, while an AVF is a direct artery-to-vein connection. On imaging, you might see prominent or even calcified draining veins. Fourth, vasculopathies, and these include cerebral amyloid angiopathy, reversible cerebral vasoconstriction syndrome, RCVS, and vasculitis. RCVS, for example, shows reversible arterial narrowing and is often linked to vasoactive drugs or postpartum states. These causes often produce multifocal hemorrhages rather than a single central bleed. Fifth, venous thrombosis. If you see subarachnoid blood, look carefully for a hyperdense or expanded venous sinus. That's the clue. Sixth, perimesencephalic hemorrhage. This is an important one to recognize. The blood is limited to the basal cisterns around the midbrain and pons, especially the interpeduncular cistern. It's spontaneous and benign. No aneurysm is found, and it's thought to be venous in origin. Patients generally do very well. And finally, iatrogenic causes, for example, after a lumbar puncture or neurosurgical procedure. Let's end with 4 high-yield reminders. 1. Aneurysmal SAH usually centers on the basal cisterns. Perimesencephalic SAH stays around the midbrain. 2. Always exclude trauma first. Location and pattern help. 3. Don't miss mimics. Hypoxic brain injury and polycythemia. 4. If posterior fossa or foramen magnum blood, think pica aneurysm or spinal AVM. In exams, pattern recognition and cause correlation are the keys to confidently reporting subarachnoid hemorrhage.